Hello, and thank you for joining us today. My name is Abbie Cornett, and I'm the patient advocate for IG Living Magazine. This podcast is brought to you by IG Living Magazine to give readers an opportunity to hear from healthcare experts on topics important to them. Issues geriatric primary immunodeficiency patients face when accessing treatment. In this episode, we will be talking about issues geriatric patients with a primary immunodeficiency face when accessing care. Today, we have guest expert, Dr. Roger Kobayashi. Dr. Kobayashi is a clinical professor at the University of California, Los Angeles School of Medicine. In addition, he is a national consultant for the Immunodeficiency Foundation. Because of Dr. Kobayashi's extensive work in clinical care and research, he is an expert on challenges faced by immunodeficient patients and their families. Good morning, Dr. Kobayashi. I want to thank you for joining me. Dr. Kobayashi, in recent years, you and I have been writing and speaking about the increasing number of geriatric immunodeficient patients and the challenges they are facing. You did a presentation at the Immunodeficiency Foundation National Summit in 2020 titled Primary Immune Deficiency in Geriatric Patients, Preserving the Golden Years. I thought we could cover some of the issues that you discussed in that presentation and expand on them for our listeners, and also talk a little bit about some of the increasing issues they're facing due to COVID isolation. The first question I have, Dr. Kobayashi, is several times over the last few years, you and I have discussed the looming issue of the aging population of baby boomers, metaphorically called the tsunami, the silver tsunami, and how the healthcare system is not prepared to meet their needs, let alone the needs of geriatric immunodeficient patients. Can you please explain to our listeners why this is a new phenomenon?
Well, thank you, Abby. I would have to chuckle a little bit. I did not realize that I was part of the golden tsunami, but I would like to thank you again because this is an increasingly growing group of patients within the PID population. I think the thing is that they have unique problems, which if we don't deal with them effectively, it will have serious medical consequences as well as serious health costs for all of us. And all of us know that health cost care is skyrocketing. Before I go on to answer your question, I'd like to point out perhaps 6 major points that I would like the audience to remember. And number one, and most importantly, is that PID, or primary immune deficiency, is not only a disease in infants and children, but it is in fact far more common in adults and the elderly. And this is a surprise, but failure to recognize this is going to cost us not only in terms of inadequate care to this age group, but also in increased costs. The second point is that it is absolutely amazing that despite the heroic efforts and praiseworthy efforts of the IDF, the Jeffrey Modell Foundation, the American Academy of Allergy and Immunology, Clinical Immunology Society, and many others, that these patients are still not recognized. The third point that we would like to make is that geriatric primary immune deficiency is a unique subgroup with complex characteristics, which include the coexistence of multiple serious chronic diseases, which impact their disease, primary immune deficiency, and we still don't fully appreciate, recognize, or understand. Fourthly, the lack of ability to effect, they have a lack of ability, the elderly in general, and the primary care immune deficiency patients in general, and specifically with our healthcare system. For example, the internet and your means of communication is foreign to our elderly patients, including myself. I don't consider myself a nerd, but I have used computers since 1966, and I tell you, it is complex. The fifth is that the elderly have decreased mobility, and this is something that we in the general population fail to appreciate. They also, even without immune deficiency, without COVID, were socially isolated because of the way we deal with the elderly group. We sort of put them out of mind and out of sight. We have a lack of support system for these individuals. And unfortunately, as we get older, we get more confused. And I think this is also an issue. Second to the last is that our healthcare system is extraordinarily expensive, very complex, and highly bureaucratic. And unfortunately, the healthcare reimbursement is being administered by federal government, which makes it even more complicated. And finally, our healthcare system is trailing in terms of effectively understanding and accommodating the unique requirements in caring for this group. So why geriatric PID? Number one, this is not a new phenomenon. We actually expected and anticipated this for decades. People are living longer. We have improved diagnostic methods. We have better treatments. And we also appreciate the association with other diseases such as cancer and autoimmune disease, which may be associated with primary immune deficiency. Secondly, patients are living much longer. Life expectancy in the 1900s were in the early 40s, early 40s. Now it's approaching 80 years of age. And the longer we live, as you know, the more things that can go wrong. We're just like old machines. We break down. We're jalopies. Our gas gauge doesn't work. Our tires get worn out, and arthritis and other degenerative diseases set in. We also have lifestyle diseases which have occurred, and diseases of aging. The other thing is that we have increased recognition of primary immune deficiency, certainly in the younger age group, but hopefully in the older age group. And there have been breathtaking developments in terms of medicine, antibiotics being the first. It's hard to imagine, but 30, 40, 50 years ago, all patients with primary immune deficiency died because of the lack of antibiotics. We now have IVIG, sub-Q IG, which helps take care of many of these patients, but these are not cures. These treat the symptoms and the problems. We have not cured the diseases. Transplantations, genetic intervention, anticipation, and prevention of the complications have all helped to make these patients live longer. However, there's no such thing as a free ride or a free meal. We can look at these advances sort of like a two-edged sword. Number one, patients live longer, but you cannot completely cure many of these diseases. And for example, hypogammaglobulinemia, we can treat and oftentimes effectively, but we cannot cure. So what does that mean? You generate a whole new series of downstream problems resulting in chronic, oftentimes extremely expensive and complicated management. Secondly, the amazing thing is that despite the fact that many in the healthcare system are sort of aware of immune deficiency, they still do not consider it as a problem. It is not rare. And in fact, we and others have done studies, in our case studies, to look, and we found that patients who are over 60 years old have far more commonly on immunoglobulin than patients under 20. In fact, about 4 times more common. So this is something that we have to appreciate. And finally, in addition to managing these longer surviving immune deficient patients, we are also diagnosing older new patients who often have repeated infections and complications such as bronchiectasis, chronic lung disease, and other complications, which make management much more complicated and expensive. So in summarizing that long answer, primary immune deficiency in the geriatric age group is an increasing problem. I would argue a much more common problem, perhaps, than the young infants and children.
Dr. Kobayashi, thank you so much. That was a very good explanation of how we arrived at the problem. The second part of my question is, you mentioned that the older generation have trouble dealing with technology. And technology is rapidly changing how healthcare is being provided in many ways, from how patients access their medical records, make doctor's appointments. And since the pandemic, it's even changed how they meet with their physicians, with telehealth. How do you think technology impacts geriatric patients? And can you please explain what your biggest concern is for geriatric patients and technology?
Yeah, I think, technology is a wonderful thing. I'm from a family of engineers. My father was disappointed that I didn't go into electrical engineering rather than medicine. Technology is a wonderful thing. We don't have to go to libraries. We can order pizza on the internet and all of these kinds of things. But I think sometimes technology is the vigorous tail that wags the dog. And unfortunately, the people who manage and implement technology are what I call computer nerds who sit down on the rear ends all day thinking that the rest of us absolutely know how to do technology. And I would argue, and a good case in point was when we first introduced vaccinations and we had online sign up for COVID vaccines. I would say the vast majority, 99% of the elderly had a hard time getting online, if at all. And even normal, highly technologically skilled individuals had a hard time getting online. I think there are several serious issues which confront the elderly. First of all, the technology is so rapidly advancing that in medicine, even to make an appointment, even to check your laboratories, even to get notified by the doctor, now you have to go online to make appointments, for example. You call the doctor's office and you get 10 choices. And then when you press the fifth choice, you get 10 more choices. So it's very difficult to interact with the healthcare system. Try to interact with your hospital, try to interact with your lab, try to interact with your pharmacy to get medications. It's very, very complicated. And it's bad enough to try, for example, now with the airlines, people's flights are getting canceled, they're getting delayed, and even the smartest, what do they call these, road warriors, they have a heck of a time trying to interact with the internet system, trying to change their reservations. Can you imagine something more serious than that? I mean, so what if your vacation got delayed? But imagine if it's your healthcare system. The other thing about the internet, if you will, is that there are so many people now involved, so much information that's being generated by these computers that things get missed. Let me give you a couple of examples. Number one, my wife's mother has Alzheimer's. She also has kidney disease and she has significant heart disease. And when she went to see multiple specialists in Georgia, and I'm not picking on Georgia, she just happens to live there. Every single one of those doctors did not look at the medical records. They put down her mental status is completely normal. Her heart was completely normal when she was in congestive heart failure. Her kidneys are fine when she had diabetes and kidney problems. And she lost 40 pounds, and they said everything was fine. And the problem is that the healthcare system is so complex, the amount of information is so overwhelming that it's difficult even for people skilled in the area to extract information. And when you're dealing with older people who have a hard time even ordering a pizza or an ice cream online, can you imagine when you have to deal with this highly complicated healthcare system? And finally, the elderly are much more complicated with multiple healthcare problems, dealing with multiple different specialists, laboratories, pharmacies, hospitals, etc. The healthcare system has made it much more difficult with the internet and neurotechnology for the older people to interact. Let me give you one more example. When I was transferring airplanes in San Francisco about a month ago, I got hungry, and they, of all things, they had a Vietnamese sandwich vendor at San Francisco International Airport. So I went to order a Vietnamese sandwich, and much to my amazement, everybody was there ordering online with their smartphone. But when they went with their smartphone to get the order, they were yelled at by this young guy who said, you didn't put this in, you didn't put that in with your smartphone. I went up, I didn't order by the smartphone. I just said, I want a regular Vietnamese sandwich. So the guy got angry. He says, well, why didn't you use the smartphone? I said, because you're standing right in front of me and I just want to regular sandwich. I don't want chili peppers. I don't want anything else. Well, he didn't know what to do because he was a, I hate to say it, but a damn nerd who was so, he didn't know how to interact with people. He was more interested in looking at his computer terminal. And he was aghast that I didn't know how to order something on the smartphone when he was right there. I mean, why did somebody give us a voice? Why didn't he, I mean, get rid of those kinds of guys? And I'm pretty adamant about this. The healthcare system information is being developed by these kinds of people who don't know how real people interact with each other. And in the case of healthcare, it is absolutely critical that you get accurate pieces of information. And I hate to say it again, just the facts, man. Again, the healthcare system, I hate to criticize, but Children's Hospital in Omaha, when I got their medical records in the old days, if a kid had strep throat, the doctor would write strep throat, penicillin, 3 words. I got about a 200-page document of hospital records from Children's on this patient that I was evaluating. And among them were 8 pages just to talk about strep throat. So I had to go through 8 pages to figure out this was a visit for strep throat and what the heck they were doing. So can you imagine the elderly with complex health problems, dealing with multiple different kinds of entities, ranging from specialists to hospitals to labs to pharmacies to home infusion companies, etc. Navigating all of this and getting frustrated because they can't interact. So what is the default position? They go further into isolation. And the problem is COVID has magnified all of this and has made it a perfect storm to isolate them even further. And it has also put a burden on our system because many people now have left. The nurses have left the healthcare system, a lot of people. And so we're getting like the airlines. We have increased demand with decreased ability to handle this on a personal level. And getting to my largest concern about the complex technology is that it is far more difficult, even for the most educated and technique savvy individual, to take care of them. The big example is signing up for the COVID vaccine. I mean, you couldn't get on, the website had problems. You had no idea where the thing was going. And then finally, when you got on, you had other choices. I mean, it's kind of like making, I flew 1,000,000 miles when I was about 35. And now when I try to make airlines reservations, I click on something and then it says, nope, that's not available. And then when you go back to try and do something else, the thing has changed all of a sudden. I mean, a simple thing like that. Can you imagine dealing with our healthcare system where you have reimbursements? I found out the hard way that when we were going on vacation, I thought, what the heck, I'll just get some antibiotics just in case my grandkids get sick or something. But when I got it at Walgreens, it cost me $3 for one prescription and $7 for another. Well, my insurance changed, but I assumed that if I went, now I had to go to CVS. And when I went to CVS, I didn't know, but for the same medications, it now cost me $140. And I said, well, wait a minute, like what's going on? And the pharmacist says, well, if you ordered the 875 milligram one, it would have cost you $40. You ordered the 500 milligram one, which is less than 875 milligrams, the last time I heard, and it's $90. Well, how would I know that? Now imagine the elderly dealing with a laboratory test or a medication or a home infusion company or going to a specialist that wasn't in network and all of these kinds of complications and to try and figure out what's going to be reimbursed. It's overwhelming. And the take-home message is that the system is geared to satisfy itself, not to serve the elderly, not to serve the patient. We need to ask ourselves, the nerds out there, you are serving the patient, you are serving the elderly, you need to find out what they can do and how they need to interact with their system. Who cares of whether I get no chili peppers on my Vietnamese sandwich? But the fact that they may miss treatment, the fact that there's a laboratory test out there and they were notified by the internet, but they didn't know. could have serious implications on these individuals.
I can't agree with you more. When you were talking about scheduling tests, I was trying to schedule appointments for my daughters to have COVID tests in Los Angeles, where I live. It took me hours to figure it out because it kept coming up booked, and then you'd have to start over. It was kind of a nightmare. So I mean, it's not just the elderly that are facing technology problems, but I can certainly see how it would impact them harder. That brings us to my third question. Technology is a big issue, but the elderly also face a number of other issues when accessing healthcare, such as memory issues, lack of mobility, and cognitive issues. Can you discuss the complexity of the healthcare system and how it does not address these issues for geriatric patients? And I'm sure it's similar to the issues of technology, but discuss some of the consequences of not addressing the mobility issues and cognitive issues.
Yeah, again, let's take away technology. Let's go back to the old horse and buggy days. I mean, taking care of the elderly was much more complicated even then. I mean, they had multiple chronic health problems, which were complicated. And I've been a doctor for 50 years, so I kind of knew how things were before all this electronic means of communicating with patients. And it was very difficult because you had these complicated patients with heart disease, diabetes, high blood pressure, memory loss, severe arthritis, so they had problems taking medicines or doing things. And then they couldn't remember. And then when they would come, they would put out 30 pills that they were supposed to take. I mean, how can you, I can't even remember to take my vitamin pill in the mornings, and I don't take them. Can you imagine if I had to take 30 medicines? And what happens if I forget and I said, oh, I forgot, so I'll take double the amount since I forgot yesterday's one? I mean, all of these kinds of things, because of it, it's so much more complicated to take care of the elderly patients. And you're taking care of people who don't have the facilities of a 21-year-old person in terms of taking care of them, both mentally, physically, and in terms of remembering things. And so this is a problem. You have the impact of cancer, you have the impact of heart disease, you have the impact of high blood pressure, you have the impact of arthritis. I mean, I have patients who couldn't open the bottle to transfer gamma globulin. They couldn't get the syringes. They have kidney problems. So if you're giving intravenous gamma globulin, we just have a paper published on being very careful if you're giving IVIG to patients who might have underlying kidney disease that you didn't know. The point that you bring up in terms of memory loss is absolutely critical. I mean, these patients are frail. They're not 21 years old. I mean, I play golf with a bunch of old geezers who in their mind think they could still hit the ball 250 yards, and they're looking way downfield when their ball is 100 yards behind them. I mean, the elderly are frail. They have decreased mobility. They can't get up. Simple things like getting into the car and driving to a doctor's appointment is a huge problem. They might have to be walkers and everything else. They have memory loss. I have a couple of patients that they can't even remember to do sub-Q IG. You have multiple specialties managing with multiple medications. And I've told you that all of these specialists who were taking care of my mother-in-law with Alzheimer's all of them said her mental capacity was perfectly normal because they were so busy entering data, they didn't look at the past records. The other issue is because of their frailty, because of their inability to remember, how do we know that they're doing subcutaneous gamma globulin at all on regular basis? We don't monitor these individuals. What we do is we mail them the gamma globulin. We assume that they're taking the medicines as they're supposed to. We assume that they're doing well when in fact they can have chronic lung disease, which is getting progressively worse. They might even land in the hospital with pneumonia, and we did not know because they were not taking the gamma globulin on a regular basis. And the problem with gamma globulin, as you know, is if you miss a dose, you still feel perfectly fine. because you don't get into trouble until it's kind of like the batteries nowadays. In the old days, if your car battery was wearing out, your car would go kind of, and you would know your battery's getting down. Now your battery works perfectly fine in the morning. And then at 5 o'clock in the afternoon, when you're all ready to go home and go out to dinner, your car is dead. And it's kind of the same thing with antibody deficiencies. You don't get into trouble until some bacteria comes along. Who is infusing gamma globulin? Do they need a caregiver? We don't know that. And what made me interested, I'm a pediatrician by training, but what made me very interested in the geriatric problem was I had two wonderful couples that I took care of. One was a retired Supreme Court justice who took care of his wife, and he did everything like a good, faithful husband should do. And then unfortunately, he got a stroke. And all of a sudden, she wasn't being treated. And we didn't know that until she got sick. And I had another couple that you always remember certain patients, but this was a couple like out of an American 1950s television, Ozzie and Harriet, that just the perfect American couple. And she had severe lung disease. We diagnosed her at the request of the pulmonologist. He took wonderful care of her, and she got much better. But unfortunately, he developed Alzheimer's. And so he couldn't get the stuff, he couldn't take care of her. And she worried about him. And then shortly thereafter, she died. And I said, what is going on here? Who is taking care of these older patients? What are their needs? If they are, like, for example, Optum has 500 patients with who are over 65 on IVIG. What are their conditions? If you want to transfer them to subcutaneous gamma globulin, can they do it at all? I mean, a lot of these things we don't know. And we have often geared our healthcare system, I'm going to finish up in the next minute or two, but we've geared our healthcare system to fit our perspective and our needs, and not necessarily that of the patient. And this is the thing that sort of disturbs me the most. The patient exists for our convenience. You come when we want. You do these things when we want. You do this. We never turn it around and ask, like, for example, as a pediatrician, we would get upset because the mothers wouldn't show up with their kids or they would come late. Well, the mother works. The mother has to cook. The mother has to take care of the kids. The mother cannot take time off nowadays from work to take the kids to all these doctor's visits. Well, the same thing with the elderly. What are their needs and how can we serve them? And I remember when I was at UCLA, I said, without the patient, no UCLA, no Medicare, no Medicaid, no insurance companies, no hospitals, no pharmaceutical industry, no home infusion. None of this would exist without the patient. And yet we look at the patient as you are there for our convenience. And this geriatric age group has increased, not only in terms of other healthcare problems, but in terms of primary immune deficiency, compounded by other healthcare problems and limitations that we have. And we need to address these issues. I don't want to be pessimistic because we have made great progress in many areas in taking care of these individuals, in terms of medications, in terms of diagnostic advancements, in terms of preventing disease. We've made wonderful progress. But I would argue we have not done enough. We're just scratching the surface. We have created, with all these wonderful developments, downstream complications which we need to address. People are living longer. People with severe chronic disease are living longer, but it means that they're more complicated to take care of. And we need to anticipate these things, because if we fail to do this, not only will these patients suffer in terms of medical problems, but we will all suffer in terms of increased unnecessary healthcare costs. We have to change our way of thinking and our perspective. not how we want the elderly to interact with our healthcare system, but how our healthcare system can interact with them and serve them in the fashion that they deserve to be served. This is what Tom Brokaw called the greatest generation. And I think we owe it to this age group to serve them in the proper fashion. Thank you.
Dr. Kobayashi, before we wrap it up, I have one comment to make. One of the things that I have worked on through my continued studies became very apparent is the healthcare industry is the only service industry that isn't set up as a service industry. People do not realize that it's no different than going to get your car repaired in a lot of ways, or going to a restaurant, other than it's even more important than any of those things. And the person that is purchasing the service, the patient, is the last person that's considered, which is completely different than in any other service industry. And I'm glad you touched on that. Dr. Kobayashi, it has been a real pleasure to have you as our guest today. And I want to thank you again for joining us to discuss the issue of aging immunodeficient patients. I'm sure our listeners found it very informative. Listeners, thank you again for joining us today. Additional information regarding this podcast can be found on our website at www.igliving.com. If you have questions that were not answered today, please contact me at acornett@igliving.com. Look for our next IG Living podcast announcement on our website for the opportunity to submit your questions or topic suggestions. IG Living Advocate is a copyright production of IG Living Magazine, published by FFF Enterprises, the only magazine for immune globulin community comprised of patients who suffer from chronic illness and their caregivers.